Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. So, in this today's very important topic, we are going to discuss and fix two to three very important questions for our upcoming exams. So, as you know that the OBJ is the major subject for your upcoming NORCET exam and JIPMER, KGME, SGPJ, any exam you are writing. In the last 5 to 6 NORCET exams, and if you want to take the other exams also like JIPMER, SGPJ, KGMU, and other exams. There is definitely fix one question from the non-stress test, cardiotocography, biophysical score, and interpretation of these particular images. Yes, whether this is an early deceleration, whether this is a late deceleration, or whether this one is a variable deceleration. So the image will come in front of you as a image based questions, and you people again will land into the confusion that whether it is on the late deceleration or the early deceleration or the variable deceleration. So in this particular video module, I am going to teach you a very important tricks, tips, and what to identify in the image to give the correct answer and to score the good rank in the exams. So if you want to solve this particular image based questions means you have to be very strong with the basics of the non-stress test and basics of the cardiotocography. If you are directly coming and watching to solve the images means that is difficult. Again you people will land into the confusion and it will be like may get correct answer or may not get the correct answer. So if we know that this question is coming in the exam and we are not preparing strongly on this particular topic means that is our mistake, right? So we have to come out of that mistakes and we have to very clear about the concept which is repeatedly striking in the exams. So I am going to teach you from the very basic to the very advanced on this particular topic. So let's start this particular topic with the fetal monitoring. Okay, so the real topic or real game starts with the fetal monitoring. Okay, so let's begin the session. Okay, students, in the fetal monitoring, we will study two very important modules. One is external fetal monitoring and another one is the internal fetal monitoring. So what is the external fetal monitoring? In the external fetal monitoring, we are using the some transducers or we are using some leads which is applying externally to the mother abdomen and which is measuring the fetal heart rate and which is measuring the uterine contraction. We are not doing any invasive procedures and we are not directly touching to the uterus and we are not directly touching to the fetus. So here just externally we are applying the electrodes. So that electrodes are the transducers which is measuring the fetal heart rate and which is measuring the contraction of the uterus. So that is what we call the external fetal monitoring. Okay. So in the fetal monitoring we will study two very important things. That is one is the yes, a electrode we are applying electrode or the lead we are applying to the mother abdomen externally. So this is what we call as the external fetal monitoring. Okay. So this external fetal monitoring, if we are during the antenatal period, okay. So if we are doing this one in the antenatal period means a period of the pregnancy, okay, from the conception to till the onset of the labor, okay, before the onset of the labor. So this is the antenatal period. Okay, in this antenatal period we are doing means just we will focus on the fetal heart rate. Okay, because during the pregnancy there is a no any significance of monitoring the fetal significance of monitoring the there is no any significance of monitoring the uterine contraction. Just we have to focus on the whether the fetus is healthy or not inside the mother uterus. Okay, so just we have to monitor the fetal heart rate, okay, in the very important antenatal external fetal monitoring. So that will be we are using here as the non-stress test. Okay, so basic model we are using here is the non-stress test. Okay, so the same fetal monitoring if we are doing we are doing that one during the labor means, so that is what we call as the in the labor we need to assess two things. One is the fetal heart rate monitoring, along with that the maternal uterine contraction. Okay, so that is what we call as the CTG. Okay, CTG, the cardiotocography. The cardio stands here as what? Cardio stands here as the, yes, fetal heart rate. Toco means a contractions, the maternal uterine contraction. Okay, so here we are monitoring both the fetal heart rate and the maternal contraction. So that is the cardiotocography. Hope it is clear to every one of you, right? So if in case during the labor process I am rupturing the membrane of the fetal membrane or amniotic fluid membrane, what we can say, that one I am rupturing, and directly I am applying the electrode directly to the head of the fetus. Means I am doing the invasive procedure here, and the electrode or the transducer what which is there, I am directly which is applying to the fetus head. So that is I am doing the, I am going inside the uterus and I am going directly touching the fetal head. So that is what we call as the, we are going inside the uterus. So that is the internal fetal monitoring. Okay, so that is the internal fetal monitoring. In the internal fetal monitoring, where the transducer is applied, yes, the transducer is applied at the, transducer is applied at the fetal head. Okay, so electrode or the lead we are applying directly to the fetal head by rupturing the membrane. So that will what we call as the internal fetal monitoring. Okay, that one what we call as the internal fetal monitoring. And this internal fetal monitoring by rupturing the membrane only done during the labor only. We will not do this one during the antenatal period. Okay, so hope it is clear to every one of you. Yes, what we have studied here in the fetal monitoring. Okay, so in the fetal monitoring mainly we have studied the two things. One is the internal fetal monitoring, that is where the electrode we are directly applying to the fetal head. So that is the internal fetal monitoring. And if we are transducer or the electrode we are applying to the mother abdomen, that is the external fetal monitoring. This is the very basic thing. Okay, so one thing we will study in detail. So in the external fetal monitoring, I told during the antenatal period, if we are doing means, so during the antenatal period, the before onset of the labor we are doing means, so we will do the non-stress test. Okay, so we will do the non-stress test. Here we will only monitor the fetal heart rate and its characteristics on the graph. Okay, so if we are doing that one during the labor, okay, if we are doing that one during the labor means we will do the, we will assess for the both the thing. Both means which thing? One is the mother uterine contraction, another one is the fetal heart rate. Okay, so here we have to do the cardiotocography. Means cardio means the fetal heart rate we are monitoring, along with that the toco means the maternal uterine contraction we are monitoring. Okay, so this is the very important thing what we have studied till now. Okay, so I hope no any doubts regarding this one till this. Okay, so now I will start beginning with the non-stress test. Okay, so which is very important. So I will give a brief description and the actual procedure what we have to follow, and the interpretation of the non-stress test is the very important for the exams. Okay, so that one we have to study with extra carefulness here. Okay, so the non-stress test is done in the all the high risk pregnancy women. Okay, so when we have to whom we have to do the non-stress test, to all the high risk pregnant women. Okay, so means a pregnancy with no any high risk, is that necessary of the non-stress test? Yes, WHO recommends at least one time we have to do. Okay, if there is no any high risk, but if there is high risk, so we have to monitor it very closely. Okay, so in the all high risk pregnancy woman, so we have to doing the non-stress test. Okay, so why we are doing? It is very simple to monitor the fetal heart rate. Okay, why we are doing the non-stress test? We are monitoring this one. We are using this one to monitor the fetal heart rate. Okay, and its characteristics on the graph paper. Okay, so that is the very important thing why we are doing the non-stress test. Okay, so in the non-stress test, this is a screening test. Okay, it's not in a final diagnostic test. So in the non-stress test, what we are doing, that is the NST is the screening test. Okay, so in this one, if this NST comes normal means, so that is what we call as the reactive NST. Okay, if this NST comes normal, so that is what we call as the reactive NST. If in case, if in case this particular NST it comes abnormal, so that is what we call as the non-reactive test. So I told the NST is the screening test, NST is the screening test, so it is coming abnormal now. So I call this one as a non-reactive test, Okay, so when there is the NXT is non-reactive, I have to go for the confirmatory test. So the confirmatory test is the biophysical score. So in the biophysical score, we have to study the five important parameters. Okay, so by using the ultrasonography, by using the with the help of the ultrasonography, five important parameters we will monitor in the this particular biophysical score. Okay, so some golden points on the non-stress test. The non-stress test is done after the 28 week. Okay, so after the 28 week in the third trimester we will recommend mostly. So the NST will be done after the 28 weeks. Okay, so I told we have to apply some electrodes to monitor the fetal heart rate in the NST. So where to apply the electrode? So this question will comes in your exam. Okay, so this is your exam question. The location of application of the Okay, so the location of the application of the lead or the transducer, okay, where we have to actually attach that lead or where we have to actually attach that transducer in the NST is, so the location will be, we have to find out, okay. So look at this image, Bacho. Look at this image. So this is the NST machine. So this one is the non-stress test machine. And here is the mother, okay. So this is the mother abdomen, okay. So here we are giving the one button to the mother, okay, and here is the transducer we have applied. Okay, so are you able to look at this image? Focus here. This particular sorry, this particular uh, what you can say, the pad like thing what we have kept here, that is the transducer. Okay, so here's the on the transducer there is the button is there. Okay, so on that one we have applied the what we can say, a belt. Okay, so that is the very important thing what we have to monitor here. Okay, so look at this one. Okay, so this is the NST machine. Okay, from the machine this paper is coming as a graph. Okay, this paper is coming as a graph here. Okay, so this is how we have the actual process will goes on. Okay, so the location of the lead or the transducer attachment is the, yes, before applying the transducer we have to do the leopard maneuver. Okay, so in the leopard maneuver we will study the four important leopard maneuvers. So that one your OBG teacher already he sir have discussed in detail in the OBG lectures in the app. Okay, so you can watch that one. So just I will tell the a very important brief thing that which maneuver we have to do in the before attachment of the NST lead or the NST transducer, the leopard maneuver second. Okay, so that is the lateral maneuver we have to do. Five means we have to assess the where actually the fetal back is present. Okay, so where the actually fetal back is present at that side, so we have to go towards the head. Okay, fetal back side towards the head we will attach the transducer which is near to the heart of the fetus. Okay, so which is near to the heart of the fetus. Why? Because what we have to monitor here, we have to monitor here the fetal heart rate. So that is the reason we have to attach the transducer near to the fetal heart. Okay, so to attach it near to the fetal heart we have to palpate the back of the fetus. Okay, and below the head, okay, at the back of the fetus, so we have to attach the very important lead or the transducer. Okay, so very important we have to know here. So do the leopard maneuver number second, so that is the lateral grip. Okay, so then identify the back of the fetus, then attach the transducer at the neck. Okay, near at the heart of the back of the fetus. Okay, this is the very important. Then next comes to the interpretation of the non-stress test. So first I will tell you what is the normal. Okay, then I will go for the what are the abnormal things. Okay, so in the non-stress test, a basic thing we have to study is the normal thing. Okay, so in that one the fetal heart rate is the very important and fundamental thing we will monitor. Okay, so the normal fetal heart rate should be comes in between the 110 to 160, 110 to 160 beats per minute. Okay, it is beats per minute will be the fetal heart rate. Okay, what is the normal fetal heart rate? Fetal heart rate should come, so that is the 110 to 160 is the normal fetal heart rate. Okay, which is actually normal, right? So then we will assess for the beat to beat variability. So what is the beat to beat variability? Okay, so a heart rate should vary from one beat to the another beat. Okay, so that is what we call as the beat to beat variability. Okay, fetal heart rate should continuously changing. Okay, so it should not be stagnant. Okay, continuously it is coming 125, continuously it's coming 130, it's not in good sign. Okay, so it should vary between the 5 to 25 beats per minute more or less. Okay, so but within the normal range. Okay, within the normal range. So beat to beat variability normally it should present normally. Okay, so fetal heart rate continuously changes, okay, within the normal range. So that is what we call as the beat to beat variability. So it is changes will happens between the 5 to 25 beats per minute only. Okay, not more than that. And the next component is the sinusoidal heart rate pattern. Okay, so sinusoidal means it will comes into this sinusoidal way. Okay, so how it is coming here? So this is the what we call the sinusoidal way. Okay, so this is what we call sinusoidal way of the our fetal heart rate pattern. So this should not come. Okay, so if it is coming, so that is the abnormal. Okay, so the sinusoidal heart rate pattern should be absent. Okay, so in the normal we will study the sinusoidal heart rate pattern should be absent. Okay, so then next come to the fetal heart rate acceleration, the very important component of the our NST. Okay, so what it means? Acceleration means yes, accelerate the bike. Okay, so you increase the race of the bike, you increase the accelerate. Okay, you accelerate the bike means something which is increasing here. Okay, so that is what we call the acceleration. Deceleration means yes, you are releasing the race. Okay, you are releasing the race. Okay, so means something is decreasing means that is the deceleration. Something is increasing means that is the acceleration. Here the FHR acceleration means the fetal heart rate is increasing. So when it increasing, when means when the inside the mother abdomen, when the fetus will move. Okay, so inside the mother uterus the fetus is moved. So that time the 15 beats per minute for the 15 second the fetal heart rate is increasing. So that is what we call as the fetal heart rate acceleration. It should and it must happens normally. Okay, so it should be present. Okay, then only we will say the NST is normal or the NST is reactive. Okay, so fetal heart rate acceleration means when the fetus moves inside, so fetal heart rate is increasing. So when how much it's increasing? It increasing the 15 beats per minute for the 15 second. So that is indicating the healthy fetus. Okay, that indicates the healthy fetus. So these are the normal components of the non-stress test. What are the things we have studied? The fetal heart rate acceleration means the fetal heart rate is increasing when the fetus moves inside the uterus. The fetus heart rate is increasing. How much is increasing? It's more than 15 beats per minute for the 15 second. It's increasing. So that is the fetal heart rate is the present means that is the healthy baby. Okay, so that is the healthy baby. So next thing we have studied here is the sinusoidal fetal heart rate pattern. Okay, so in the sinusoidal fetal heart rate pattern, so it should be absent. It should not comes like wave like. Okay, so if the fetal heart rate pattern is coming like wave like, so that is what we call as the sinusoidal fetal heart rate pattern. So if it is present means that is the abnormal. Okay, so if it's absent means that is the normal. Okay, so this is the component we have seen. So along with that, the beat to beat variability means the fetal heart rate is variable means which is changing continuously within the normal range. So it should happens normally. Okay, so it should not be stagnant, it should not be fixed. Okay, so the fetal heart rate should come variable range. Okay, so that is the beat to beat variability. Then next one we have studied is the fetal heart rate. Okay, so that should be within the normal range of the 110 to 160 beat per minute is the normal fetal heart rate. Then let's now study the abnormal NST interpretation. Okay, but you know, normally I told the fetal heart rate should be within the 110 to 160. If the fetal heart rate is less than the fetal heart rate is less than 110, so that is what we call as the bradycardia. Okay, if the fetal heart rate is more than 160, that is what we call as the tachycardia. This bradycardia and tachycardia both are not good. If the bradycardia and tachycardia present means that is the abnormal. That is the abnormal in the fetus. So which indicates the fetal hypoxia. There is less supply of the blood to the fetus. Okay. So that time, if any oxytocin is on flow, that one first we need to stop. Okay. Then we have to give the suddenly left lateral position. Then start the oxygen with the 8 to 10 liter per minute of the oxygen with the face mask. We need to start. After that, we need to inform the doctors. Okay, so that is the fourth priority is to inform the primary healthcare provider. Okay, so what happening if the bradycardia, tachycardia is happening means that indicates there is the fetal hypoxia. Okay, very important. And in the normal thing, what I told, there will be beat to beat variability. It should be normally present. Okay, so normally beat to beat variability, it should be normally present, right? So in case the beat to beat variability is absent, means there is no any heart rate changes. The heart rate is coming fixed. So that is abnormal. Okay. So that's the abnormal. Then comes to the I told the sinusoidal fetal heart rate pattern it should not happens in the normal fetus. Okay. It should be absent normally. Okay. If in case this sinusoidal fetal heart rate pattern is present, so that is the abnormal. Okay, so that is the abnormal. So that clearly indicates the fetal is suffering with anemia. Okay, so that is the fetal anemia. It indicates. So when the fetal anemia happens, when there will be a blood which is leaking inside the baby, so means the bleeding which happens from the umbilical cord. So that is in case of the vasa previa due to the hemorrhage. So due to the bleeding there is a less blood, so fetal anemia may happen. Okay, or else the blood is getting breaking inside the fetus, so that is the due to the rh incompatibility. Okay, so the hemolysis is happening inside the fetus due to the rh incompatibility, so that time also the fetal anemia may happens. Okay, so in the rh incompatibility, okay, so or in case of the vasa previa, okay, so there is a chance of the very important fetal anemia, and if the fetus is suffering with the anemia, so there will be a sinusoidal heart rate pattern will be present. Okay, so normally it should be absent. If it's present, that indicates the fetal anemia. Very important question for your upcoming exams. Okay, so then comes to the fetal heart rate acceleration. Okay, so in the fetal heart rate acceleration, I told it should be normally present. When the fetus, I told normally what happens, this is the uterus, this is the fetus. So inside the uterus the fetus is moving like this. Okay, means that time the fetal heart rate will increases. How much it increases? It increases 15 beats per minute for the 15 seconds. So that is what we call the fetal heart rate acceleration. So if it is present, so that is the normally healthy baby. If in case the fetal heart rate is acceleration is absent, so that indicates the unhealthy baby. Very important, keep in your mind. Okay, so we have studied the all the interpretation of the NST. Then comes to the what is the actual procedures what we have to follow during the non-stress test. That is the NST procedures. Okay, so first we have to tell to the mother that this is the a continuous 20 minutes procedure. Okay, so this is the continuously 20 minutes procedure. Okay, so you should not be leaved away from the machines for the duration of the 20 minutes. If you want to go to the washroom, go now. If you want to empty your bladder, empty it now. If you want to empty your bowel, empty it now. If you want to drink a water, drink it now. And if you want to do anything, do it now. So once the procedure will be started, so it should be a carried for the 20 completed minute. Okay, so that one we have to explain to the mother. Okay, so after that, if mother is ready, then take the mother and give the semi follows positions. Okay, or we can say the reclining positions. Okay, I think you people have seen the reclining position. Okay, this is the table. Okay, so here this is not like this. Okay, it is like this. Okay, so this is what we call the reclining positions. We are keeping the patient in this particular position. Okay, so we can say semi-polus position or the reclining positions we have to give to the mother. Okay, so if both are not there in the option, go for the left lateral positions. Okay, so then after that we have to fasten the belt to the mother abdomen, and we have studied this one. And transducer should be at the back of the fetus near to the heart. Okay, and test done for the duration of the 20 minutes, and ask the mother to press the button when the fetus moves inside. Okay, so the mother only feel that one. Okay, when the fetus is moving inside, that is a mother's subjective experience. Okay, so that the mother only can feel that one. So we will ask the mother to press the button if the fetus is moving inside. Okay, when the fetus moves inside, she will press the button. So at that time, on the graph it will produce us the arrow like this. Okay, are you able to see this arrow here? Are you able to see this arrow here? Yes. So when the fetus moves inside, so that time if the mother presses the button, so it will produce the this kind of the arrow. So this indicates the mother have pressed the button along with the fetal movement. Okay. So this indicates the fetus movement. So similarly, are you able to see this particular picture here? Here, when the fetus moves inside, so that time the normally presenting fetal heart rate is suddenly increasing, and which is coming to the normal. Okay, so this means the 15 beats per minute. Okay, for the 15 second the heart rate is increasing when the fetus is moving inside, so that is what you call as the acceleration. Okay, so this is what you call as the acceleration. Similarly, we can look at here. So again, here will be a fetus movement is there. Okay, at the same time, okay, the fetus heart rate is increased. Okay, and when the fetal movement is stopped, that time, so fetal heart rate again came to the same range. Okay, so again the fetal heart rate is increased 15 beats per minute for the 15 second. Okay, so for the 15 second, so this is again we call this one as in the acceleration. Okay, so hope you people understood this one. Okay, so how many acceleration should come normally, sir? Yes, so normally how many acceleration should come, sir? Sir, I told this is the procedure done for the duration of the 20 minutes, right? So I told this procedure will be done for the duration of the 20 minutes. In the 20 minutes, two or more than two acceleration is coming, means that is the normal. Okay, so that is normal. So normal NST, we will call that one as the reactive NST. What we call this one as the reactive NST. Okay, so if in case in the last 20 minutes there will be a less than 2 acceleration, okay, in the last 20 minutes, so what we have to do, we have to repeat or we have to continue the NST 20 more minutes. Okay, so in the first 20 minutes the fetal heart rate is not accelerating. Okay, so there is less than 2 acceleration in the 20 minutes. So what is the next step? We have to uh, continue the 20 more minute of the NST. Okay, if even after doing the this 20 minutes plus this 20 minutes, total 40 minutes. Okay, so still there is the less than 2 acceleration will be there in the last 40 minutes, means so that indicates it is in the abnormal NST, or we can say this is in the non-reactive NST. Okay, so we can say this one is in the non-reactive NST. Okay, so if the non-reactive NST comes, means what is the next step, sir? I told the non-stressed test or the NST is the screening test. It's not a confirmatory test. Okay, so if the NST comes abnormal, or if the NST comes the non-reactive, that time we have to go for the confirmatory test. So the confirmatory test is the biophysical scoring. Okay, so what is the confirmatory test? So that is the biophysical scoring, right? So in the biophysical scoring, what we have to do? So we have to do it with the help of the USG. Okay, so we can't do directly with the help of the transducer or something like. Okay, so biophysical scoring or the Manning scoring should be done with the help of the ultrasonography. Okay, so the duration of the biophysical score or the duration of the Manning score, the both are same. The another name of the biophysical score is the Manning score. So this one have asked in the exam recently. Okay, so another name of the biophysical score, very very important. Okay, so keep in your mind, right? So this biophysical score or the Manning score, which will be done with the help of the USG. Okay, so the duration will be for the duration of the 30 minutes. Okay, so this will be done for the duration of the 30 minutes, and the total how many parameters are there? So here the total five parameters are there. Okay, so here the how many parameters? Total five parameters are there. So each parameters, if it is normal, means we have to give the 2 score. Okay, if it's abnormal, means we have to give the 0 score. There is no 1 score. Okay, so there is no one score is not there here. Okay, so the normal things we will give the 2 score, abnormal things we will give the 0 score. Okay, there is no 1 score. Okay, so then comes to what are the 5 important parameters of the our Manning score or the biophysical score. So this is very important for your exam purpose. Okay, the first parameter is the NST. In the NST, what we have done in the last 20 minutes and in the last 20 plus 20 40 minutes. So in that one, if the NST is reactive, means NST is normal, it means the acceleration is more than 2 acceleration we are getting in the last 20 minutes. So means that is the NST is normal or NST is reactive. So that time we will give the 2 score. Okay, so if in case that particular NST what we have done in the 20 plus 20 40 minutes, still we are getting the less than 2 acceleration, so that indicates it is in the non-reactive NST. So that is the abnormal, we will give the 0 score. Okay, so then the second very important component what we have to monitor is the fetal breathing movements. Okay, so in the fetal breathing movement we will watch for the at least one episode. Okay, so at least one episode. Okay, so that is lasting for the more than 30 seconds in the last 30 minutes, what I told. Okay, so the procedure should be done for the duration of the 30 minutes. In the 30 minutes, in the 30 minutes of the biophysical score or the Manning score with the help of the USG. So if there is a fetal lung movement or the fetal breathing movement. Okay, the more than one episode of the breathing movement, so that movement should be more than 30 seconds. At least one movement, if you are getting this, that we will give the normal score, that is the 2 score. If in case the fetal breathing movement is absent, or the movement is present but which is lasting for less than 30 seconds only, so that is abnormal, we will give the 0 score. Very important second component. Then comes to the third important components, that is the gross body movement. So the third one is the gross body movement. In the gross body movement, what we will see, so we will see the entire body movements, especially the upper and lower extremities movements. Okay, so in the gross body movements, at least three body movements or at least limb extension or flexions. Okay, so in the last 30 minutes, okay, in the last 30 minutes of the biophysical score, with the help of the USG, we are getting a three body movements in the last 30 minutes, means that is the normal. Okay, so that is the normal. If we are not getting the gross body movements or less than three movements in the last 30 minutes, that's the abnormal, we will give the 0 score. Okay, so the fourth one is the fetal tone. Okay, the fourth one is the fetal tone. So here we will study a tone or the a universal flexion of the fetus. Okay, so if the fetus is completely flexed, and there will be at least one episode of the extension and flexion in the last 30 minutes, that will we will give the 2 marks. Okay, so if there is a slow extension, there is slow flexion, and so completely lack of the flexion. Okay, so or the absent of the fetal tone, we can give the 0 scoring. Okay, so the fifth one is the, this is the fourth component what we have seen here, fourth component, and this one is the fifth component. In the fifth component, what we have to study is the, that is the amniotic fluid volume. So with the help of the single largest pocket volume, so we have to check here in the single largest pocket volume. So we'll divide the abdomen into the four. Okay, so among the four components. Okay, so we will check for the, in the which components the amniotic fluid pocket is big one. Okay, so the normally it should be a 2 centimeter to 8 centimeter. Okay, so the 2 to 8 centimeter depth of the amniotic fluid pocket is the normal one. Okay, so if we are getting one pocket, at least one pocket, at least one pocket of the amniotic fluid. Okay, so that is the 2 centimeter, or the in the two perpendicular planes. Okay, so that is the what I told. So one perpendicular plane, another perpendicular plane. In the two perpendicular plane, at least one pocket of the more than 2 centimeter we are getting, means the 2 marks we will give. Okay, so if we are getting the absent of the pocket, or the pocket depth is less than 2 centimeter, so that we will give the 0 scoring. Okay, so this is the Manning score, or what we can say the biophysical score what we are using here. Okay, so let's interpret the normal scoring, and what is the next intervention of the after biophysical score. If the biophysical score which is coming a 10 to 8, means that is the normal. Okay, that is the normal. Okay, so that indicating the very low risk of the fetal hypoxia. Okay, so that is the normal, no need to do anything. If in case this particular biophysical score, which the score is coming between the 4 to 6, means that is the fetal hypoxia. Okay, there will be a suspect of the fetal hypoxia is there, there will be a suspect is there. So when we will suspect that one, that time we have to repeat the biophysical score same day. Okay, same day we have to repeat that one, and again we have to reassess the total number of the biophysical score. Okay, so if it is coming less than 4, which clearly indicates, which is the strongly we have to suspect that it is a chronic fetal hypoxia, so immediately we have to take for the LSCS. Okay, so that is the very very important things we have seen here. Okay, so how to remember these five components of the, or the five parameters of the uh, biophysical score or the Manning score is, so it's in the five components or the five parameters of the biophysical or Manning score. Okay, so how to remember this one? So these are only five components what I thought to you people: NST, fetal breathing movements, gross body movements, fetal tone, and the single largest pocket volume, that's the amniotic fluid volume. Okay, so how to remember means remember with help of the biophysical scoring with the help of the mnemonics, that's the BAT man. Okay, so here the B stands here is the breathing movement. Okay, B stands here is the breathing movements. Okay, so if the breathing movements are present, so that we will give the 2 marks. Okay, if the breathing movements is yes, at least one breathing movements in the last 30 minutes, the movement should be more than 30 seconds, so that time we will give the 2 marks. Okay, so if the absent of the breathing movements or the movement of the breathing, it should be if it is less than 30 second. Okay, so that we will give the 0 marks. Okay, so the second one is the amniotic fluid. Okay, I told here we will assess for the single largest pocket volume. Okay, so it should be normally 2 to 8 centimeter. If it is 2 centimeter, okay, so that we will give the 2 marks. Okay, if it is less than 2 centimeter or the absent of the single largest pocket volume, so that time we will give the 0 marks. Okay, so normally single largest pocket volume depth will be 2 to 8 centimeter. Okay, so then the fetal tone. Okay, so here the T stands for the tone, A stands for the amniotic fluid. Okay, there is the single largest pocket volume. B stands for the breathing movements. Then the M stands for the movement of the body or the gross body movement of the fetus. Okay, so the last N stands here the non-stress test, where with the help of this one we are assessing the fetal heart rate. Okay, so these are the 5 important parameters how you have to remember in the non-stress test. Okay, we will study the one more thing, that is the modified biophysical scoring. Okay, so in the modified biophysical scoring, this is also screening test like NST. This is also screening test. Okay, so biophysical scoring is the where we will assessing the 5 components. Okay, so that is the diagnostic one. But the modified biophysical score, which is having the only 2 parameters, so that one is the again the screening test. Okay, so we are having the both 2 screening test. One is the non stress test and another one is the modified biophysical scoring. Okay, so these two are the screening test. If there is any abnormality in this one, we will go for the biophysical scoring. Okay, so that is the 5 parameters we are having here is the 5 parameters. Okay, so only 2 parameters which are, one is the NST. Okay, if it's reactive, that is well and good. If it's not reactive, then refer for the biophysical scoring. Okay, so then the amniotic fluid index. Okay, so the normal amniotic fluid index is between the 5 to 25 centimeter. The question will be asked in your exam. Okay, so the normal single largest pocket volume of the amniotic fluid is the 2 to 8 centimeter, and the normal amniotic fluid index is between the 5 to 25 centimeter. Very important, keep in your mind. Okay, so this modified biophysical score is the screening test. Okay, what I have told already, but the biophysical score is the confirmatory or diagnostic test. Okay, so this is what we have studied regarding the NST. Okay, so very important, quickly revise the NST and the biophysical scoring. Okay, so I am giving the quick revision of the NST again here, so you people, if you have any doubts, it will be get clear here again. Okay, so this is the NST. When we will do the NST after the 28 weeks, so to whom we will do? To all the high risk pregnancy we have to do. Why we have to do? To monitor the fetal heart rate and its characteristics, like whether the beat to beat variability is present or not, whether the acceleration is present or not, whether the fetal heart rate is in the normal condition, or it may go on to the bradycardia, or it may go on to the tachycardia. So in order to assess this one, so fetal heart rate and its characteristics we want to assess with the help of the NST. So that is the reason in case of the high risk pregnancy we are recommending for the going for the NST. Very important. Okay, so in the NST, if the NST is coming normal, so I call that one as the reactive NST. If the NST is coming abnormal, I call this one as the non-reactive NST. Okay, so if in case the NST came abnormal or the non-reactive NST, then I will go for the biophysical score. So what is the next step? Next step is the biophysical score. Okay, so that is the confirmatory test, right? So when we have to do the NST, we have to do the NST after 28 week of the gestation. Okay, so then the location of the attachment of the transducer is the, we have to palpate the back of the fetus by using the lateral grip or the second leopard minor, and the near the heart, back of the fetus near the heart, we have to attach the transducer. Very important. NST interpretation, normally fetal heart rate should be between the 110 to 160 beats per minute, and the beat to beat variability should be present, means the heart rate should vary within the 5 to 25 beats per minute within the normal range. Okay, so and the sinusoidal heart rate pattern should be absent. There should not be any sinusoidal heart rate pattern. If it is present, that indicates it's abnormal, and that indicates it's the fetal anemia. Okay, so that may due to the RH incompatibility, that may due to the Warsaw previa. Okay, so the next one is the fetal heart rate acceleration. Okay, so fetal heart rate acceleration means whenever there will be a movement of the fetus inside the uterus, so there will be a high or there will be increase in the fetal heart rate of 15 beats per minute for the 15-second duration. That is what we call the fetal heart rate acceleration. Okay. So if in case this is the normal interpretation. Okay. So if the fetal heart rate is less than 110, that's the bradycardia. More than 160 beats per minute is the tachycardia. Okay. Beat to beat variability absent means that indicating the abnormality. Okay. So the normally beat to beat variability should be present. Okay. So the next one is the sinusoidal heart rate pattern. It should be absent. If in case this sinusoidal heart rate pattern is present, that indicating the fetal anemia, or that may indicating the RH incompatibility and vasa previa, very important. Okay. So normally fetal heart rate acceleration should be present. If it is absent, so that indicating the unhealthy child. Okay. So that we have to go next for the biophysical scoring. Okay. So procedure I told, reclining or semi-polar positions we have to give, and we have to educate for it is the procedure of the 20 minutes. And if you want to empty the bowel bladder, so before that one you have to empty, we have to educate to the mother. Okay. So then after that we have to give the semi-polar or the reclining positions, or if it is both are not there in the option, go for the left lateral position as the correct answer. Then we have to fasten the belt to the mother abdomen, and we have to attach the transducer at the fetal back. Okay. And ask the mother to press the button when the fetus moves inside the uterus. Okay. So if the fetus is moves inside the uterus, so that time, okay, there will be a mother will press the button. That time a arrow will produces. Okay. Exact near the arrow there will be increased 15 beats per minute fetal heart rate for the 15 duration, 15-second duration. So that's what we call as the acceleration. Okay. So that's what we call as the acceleration, right? So in the acceleration, if it is in the duration of the 20 minutes, if there is the two or more than two acceleration, there is the normal, means there is the reactive NST, right? So if in case there will be a less than two acceleration in the last 20 minutes, that is what we call as the non-reactive NST or the abnormal NST. So we have to continue that one for the further more 20 minutes. Even after doing the 40 minutes, it is coming the less than two only. So that is what we call as the abnormal NST. Okay. So that is the non-reactive NST. Yes, if the NSTs came non-reactive means, then we have to go for what I told, NST the screening test. Now I have to confirm what is the actual problem. So I will go for the biophysical scoring or the Mending scoring. So it will be done with the help of the ultrasonography, and the duration of the biophysical scoring or the Mending scoring will be a 30 minutes, and there will be a total 5 parameters. One is the B for the, yes, the batsman is the mnemonic. B for the, yes, the breathing movements. Okay, the breathing movement of the fetus need to assess, and A for the, yes, amniotic fluid, single largest pocket volume of the amniotic fluid. Okay. So then T for the, yes, T for what? Tone of the fetus. Okay. So then comes to the M for the, what is the M? M here is the, yes, a movement, the body movement of the fetus. Okay. That is the gross body movement of the fetus is the M. Okay. So then comes to the N. N is the non-stress test. With the help of that one, we will assess the fetal heart rate. So the total 5 parameters. Okay. So if it is coming 8 to 10 out of the 10, it is 8 to 10 minutes, that's the normal. There is no any fetal hypoxia. If it is coming 4 to 6, that indicates there will be a suspect of the fetal hypoxia. Okay, that time we have to repeat the biophysical score. Okay, so if in case it is coming less than 4, the Mending score or the biophysical score is less than 4, so that time immediately go for the LSCS. Okay, so that is the very important thing. And here is the mnemonic for the our biophysical score. Okay, so and I told the one more thing, that is the modified biophysical score. This is the screening test. Okay, so the total two screening test, one is the NST, another one is the modified biophysical score. Okay, so if the both are the non-reactive, and in the both if it's coming any abnormality, we will go for the our biophysical score. Okay, so that is the very very important. So till that we have discussed how we have to monitor during the antenatal period. If that a same lady, she comes with a uterine contraction. Okay, when it comes with the uterine contraction means the labor process have begun. Okay, so that time what we have to monitor? We have to monitor the cardiotocography. I told the NST will be done in case of the high risk pregnancy only, but this cardiotocography will be done in the all the labor woman. Okay, so it will be done in the all the labor woman. Okay, so what is the CTG? CTG is the cardiotocography. Okay, so what are the things we have to monitor here? But already I have told the meaning. So that is the cardio. Cardio means, so that is the what we are monitoring. We are monitoring the fetal heart rate. Toco means, yes, the uterine contraction. So on the graph, we are seeing both a uterine contraction, and in association with the uterine contraction, how the fetal heart rate is changing. We are looking that one. So that is what we call as the cardiotocography. So here will be a two things we are monitoring. One is the fetal heart rate, another one is the uterine contraction. Means we require the two transducers. Okay, so two transducer to apply to the mother abdomen. Okay, so we require here, right? So two transducer requires means one for the fetal heart rate monitoring and another one for the maternal uterine contraction. Okay, so one is for the fetal heart rate monitoring we required and another one for the monitoring the uterine contraction. So I told to monitor the fetal heart rate where we have to apply the this particular transducer. Yes, at the fetal back near to the fetal heart we have to apply this one. Okay, so similarly if you want to monitor the maternal uterine contraction, so where we have to apply this one, so where the actual the maximum amount of the contraction will be there, so that area we have to apply the this particular uterine transducer. Okay, to monitor the uterine contraction where we have to apply the transducer, so the maximum uterine contraction will be there in the fundus of the uterus. Okay, so where will be the maximum uterine contraction is there, so in the fundus of the uterus there will be a maximum uterine contraction is there, so we have to apply the transducer at the near the fundus of the uterus. So that is the very important. So the next one is the yes. I told the NST will be done in the high risk pregnancy, but the CTG is the done in the all the labor one. Okay, so it's done during the labor. Okay, it will not be done during the antenatal period. So it will be done during the labor. Okay, so parameters of the CTG again, which is same to same like the NST, where we will see the acceleration, where we will see for the tachycardia, bradycardia, and where we will see for the beat to beat variability, and very importantly sinusoidal heartbeat pattern also we will see here. So along with this there will be a one extra thing we are monitoring, that is the plus same like NST plus deceleration. Okay, so deceleration which is not a part of the NST. Okay, which is not a part of non-stress test. Okay, so deceleration which is a part of the our cardiotocography, which is very important, keep in your mind. Okay, so what is the deceleration? So what I told acceleration means when there will be a fetal movement, that time there will be increase in the fetal heart rate 15 beats per minute for the 15 seconds. So that is the acceleration increasing. Similarly, when there will be a compression on the fetus, or when there will be a suffocation to the fetus, or when there will be a less blood supply to the fetus, so that may be due to the uteroplacental insufficiency, that may be due to the uh, what we can say fetal hypoxia, or that may be due to the umbilical cord prolapse, or that may be due to the compression of the fetal head. Okay, so when the fetal will get suffocation, so that time the fetal heart rate will get decreases. Okay, so that is what we call as then the deceleration. Deceleration means decrease in the fetal heart rate. Okay, so how much it decreases? Same as the acceleration. Same in the acceleration, 15 beats per minute for the 15 seconds, which was increasing. Okay, in the deceleration, the same 15 beats of fetal heart rate, so it will decrease 15 beats per minute for the 15 second, it will get decreases. So this is what we call as the deceleration. When it happens, so when the uterus contracts, so that time due to the low blood supply, the fetal heart rates are decreasing. That is what we call as the deceleration. Okay, so बच्चों, the acceleration, the improvement of the fetal heart rate more than 15 beats per minute for the 15 second is the normal thing. But if in case the fetal heart rate is decreasing 15 beats per minute for the 15 second, so the deceleration is the abnormal thing, which indicates there is a lack of blood supply to the fetus. Okay, so that is the very important thing. Yes, the acceleration is the normal, deceleration is the abnormal. Okay, so parameters of the CTG, that's the cardiotocography. What I told, the fetal heart rate we have to monitor, so it should be between the 110 to the 160 beats per minute. Okay, so if it is less than 110 beats per minute, that is what we call as the bradycardia, and if it's more than 160 beats per minute, that is what we call as the tachycardia. Very important thing, right? So the acceleration, it should be normally present. Okay, so that will be a increased, that will be a increased fetal heart rate more than 15 beats per minute for the 15 seconds. So this is the acceleration, it should be normally present. Okay, so then the beat to beat variability. Okay, so there will be a change in the fetal heart rate between the 5 to 25 beats per minute within the normal range. Okay, so there will be a change or variability in the heart rate will be there, but within normal range. Okay, means it will be between the 110 to 160 only, it will not crosses the 160 and it will not go below the 110. Okay, so that is the beat to beat variability, it should be normally present. Okay, so the sinusoidal fetal heart rate pattern. Okay, so like this pattern of the fetal heart rate is coming in the NST or in the CTG, so this is the abnormal. Okay, it is the abnormal, very important. So which indicates the fetal anemia. So that may be due to the RH incompatibility, or that may be due to the, yes, vasa previa and the fetal bleeding. Okay, so very important. So the one more important thing, these all things what we have studied in the NST is also a component of the CTG, but in the NST there is no deceleration, but in the CTG we will study one extra component, that is the deceleration. So this is the reason before teaching the CTC, I have given a complete brief and idea related to the NST. Okay, if you don't know the NST, you don't know the CTC. That is the simple thing. Okay, so very importantly, so we are studying the one extra thing in the CTC. So that is the cardiotocography. We are studying the extra thing, that is the deceleration. Deceleration means to decrease the fetal heart rate 15 beats per minute for the 15 seconds. So that is what we call as the deceleration. Okay, so there are total three types of the deceleration. One is the early deceleration, one is the late deceleration, and one is the variable deceleration. The word itself meaning it is the early means it is the uniform and it is the coordinated or with the uterine contraction. One is the late deceleration means when the uterine contraction happens. Okay, so after that lately there will be a decrease in the fetal heart rate. So I will discuss you briefly with the image based questions, that will be very clear to you people. Okay, so then it will be a variable deceleration. Okay, so it is not associated with the uterine contraction. Yes, the uterine contraction is happening here, and it may be a sudden decrease and sudden fall in the uterine, sorry, fetal heart rate. Okay, so it is not associated with the uterine contraction to the variable deceleration. We will study everything in detail. Okay, that will be helpful for our exam because it is very very important. So now first we will study related to the early deceleration. Okay, in the early deceleration what we have to study, that is the uh, early deceleration means the fetal heart rate is decreasing. Okay, so fetal heart rate is below the baseline, but it will never goes to less than 100. Okay, it is always more than 100 only. Okay, so fetal heart rate will be, yes, it is less than it is below the baseline, but it will not go below the 100. Okay, yes, I told here will be a normal fetal heart rate of the 110 to the 160 beats per minute. Okay, so it is less than 110. So this is the baseline. So it is less than 110, but more than 100. Okay, so this will be seen in case of the early deceleration. So which happens due to the fetal heart head compression. Okay, but so this is the normal thing. Consider, so this is the birth canal. From the birth canal, the fetus is moving down. Okay, so due to the uterine contraction, the fetal heart head will be normally compressed. So there is no any other alternative way. Okay, so usually the uterus will contract and it will compresses the fetal head. So it is normal. It is physiological. Okay, so during this time, the fetal heart rate is decreasing. Okay, so that is what we call as the early deceleration. Yes, early deceleration happens due to the fetal head compression. Okay, so it is normal. Okay, so it is normally seen. Okay, during the labor, and there is no any active treatment required. There is no any active treatment required. So just we have to monitor in the our chart. Okay, so that is the very important thing. So in the image based questions, so how it will be seen, sir? So it will be seen with a mirror image. Okay, so important. So mirror image of the CTG will be seen in case of the mirror image of the CTG will be seen in case of the, yes, it will be seen in case of the early deceleration. Sir, what is the meaning of this one, sir? Let me explain, sir. So this is the meaning, sir. So this is the uterine contraction, and this one is the fetal heart rate. Look at this one. This is the normal uterine contraction, or this is the normal uterus. Okay, when there will be a starting of the uterine contraction. Okay, so when there will be a starting of the uterine contraction, that time the fetal heart rate is started to reduce. Okay, so when the uterine contraction is in the peak, the fetal heart rate is the in its very below range. Okay, so it's in its very below range. Okay, when it is in the peak, it is in the very or the highest below range. Okay, so when the uterus contracts will relaxing, so that time the fetal heart rate is increasing, sir. So when you see this one in the mirror, so we can say that opposite, that is the mirror image. Okay, so at the beginning of the contraction, so fetal heart rate is start to decrease. Okay, so at the peak of the contraction, the fetal heart rate is in its very low. Okay, and at the release of the contraction, the fetal heart rates go back to the normal. Okay, so this is what we call as the mirror image. Okay, so this will be seen in case of the early deceleration. Okay, so this will be seen in case of the early deceleration. In this one, okay, in this one the fetal heart rate will decreases below the baseline, but it will be more than 100 only. Okay, so it will be more than 100 only, but it will be less than 110 but more than 100. Okay, it will be below the baseline but it will be more than 100. Okay, so that's the very very important thing what we have to keep in our mind. Okay, so this is the early deceleration. So how to identify this one in graph, sir? So look at this particular graph, sir. So this is the graph of the uterine contraction, this is the graph of the uterine contraction, and this is the graph which indicating the fetal heart rate. Okay, this is the graph which indicating the fetal heart rate. Sir, look at this particular point. Here is the uterus start to begin contracting. So at the same time the fetal heart rate which is there, which is coming down. Okay, so make a line here. Okay, so at the beginning of the uterine contraction the fetal heart rate is start to decrease. Okay, so when there will be a uterine contraction is in its peak, so fetal heart rate is also it is decreased, so it's maximum low level. Okay, so when there will be a uterine contraction is start to decrease. Okay, so that time the fetal heart rate is going back to normal. Okay, again we are getting here as the mirror image. Okay, so this is the what we call as the early deceleration. This is how we have to identify. Sir, look at the next image, same here. Okay, so here again is the uterine contraction. Okay, it's the beginning of the uterine contraction. Again here is the fetal heart rate is start to decrease here, right? So here at the beginning of the contraction, draw a line at the beginning of the contraction. Yes, the fetal heart rate is start to decrease. Okay, so begins to decrease at the peak of the contraction. Yes, the fetal heart rate is in its lowest point. Okay, and at the end of the contraction and the fetal heart rate is gone back to its normal. Okay, so this is what we call as the mirror image. So we will see this one in case of the this mirror image will be seen in case of the yes early deceleration which happens due to the fetal head compression. Okay, which happens due to the fetal head compression, and it is clearly normal. Okay, it's clearly normal and no treatment required. These are the point you have to keep in your mind. Okay, no treatment required. Hope it is clear. So this is a very very important image based question. Okay, so let me go for the uh, next graphical thing. This kind of the image also may come in your exam. So again on the early deceleration, okay, same thing, mirror image again. Look at this one. So this is the uterine contraction and this is the fetal heart rate. Okay, so here the uterine contraction start to begin, again the fetal heart rate is start to decrease. Okay, so uterine contraction in its maximum. Okay, so the fetal heart rate is in its very peakest, but it is not coming below the 100. Okay, look at this one. This is the 100. Okay, if it is coming less than 110 but it's not coming below the 100. Okay, so then when the fetal artery is so when the uterine contraction releasing, then the fetal artery is gone back to the normal. Okay, so this is the early deceleration. Similarly, so we will see in case of the our fetal head compression. So the next one is the late deceleration. Okay, so in the late deceleration, the word itself it is telling it is the late. Okay, so late deceleration. So here the fetal heart rate is below the baseline, means it is below the 110, but the most importantly it will not completely associated with the uterine contraction. Yes, it's associated but not completely, I can say. So why, sir? Why means, so look at this particular image. So I will make clear your concept so it will be helpful for you all. Okay, so this is the what I am drawing here now is the uterine contraction. Okay, and here I will draw the fetal heart rate. Okay, so deceleration means the fetal heart rate decreasing. Okay, so look at this. Now the uterus is started to contract. Okay, so uterus is contracted and it is came normal, then contracted and it is came normal. Okay, so when the fetal heart rate will decreases in the late deceleration, means it will decreases late. So in the early deceleration when it was decreasing, so first I will draw the early so it will be helpful to differentiate. Okay, so look at this. In the early deceleration, when the uterus is started to contract, that time the fetal heart rate is started to reduce. Okay, so when the uterus will relax, so that time fetal heart rate will come to normal. So this was happened in the early deceleration, but this is the late, means it will happens the late. Okay, so when the uterus will be contracting on its peak, on its peak, that time the fetal heart rate will start to reduce. Okay, so the beginning of the fetal heart rate decrease will be at the peak of the uterus. Okay, but in the early deceleration, we look at this. The beginning of the fetal heart rate reduce will be at the beginning of the uterine contraction. Okay, so uterine contraction is beginning, and fetal heart rate is start to decrease. But in the late deceleration, so beginning of the decrease in the fetal heart rate, so fetal heart rate deceleration decreasing start to decrease when the uterus in is its peak of the contraction. Okay, so means it should actually happens here. Okay, it should begin from here, but it is not beginning, it is beginning from the uh, peak of the uterine contraction, means there will be a late will be there, there will be a delay will be there. So that is what we call as the late deceleration or the delayed deceleration. Okay, so this is what we call as the delayed deceleration. Okay, again same thing happens here. Okay, so when this uterine contraction is in the its peak, that time the fetal heart rate will start to decrease. Okay, so this will be seen in case of the late deceleration. Okay, so look at the graph, but so look at the graph here, so you will be get more clarity. Okay, so this is the uterine contraction, this is the uterine contraction, right? So this is the peak of the uterine contraction. Take a line, straight line here. Here the fetal heart rate, it is start to decrease. But look at the image, look at the early deceleration graph. Here the uterine contraction is beginning, so same time the fetal heart rate is started to decrease. Okay, but in the late deceleration what happens, so the fetal heart rate is started to decrease when the uterus is in the contraction. But in the early deceleration, when the contraction started, that time only the fetal heart rate was decreasing. But in the late deceleration, it is decreasing late. Okay, so when the uterus is the peak of the contraction, that time the beginning of the very very important fetal heart rate decrease will be happens. Okay, so that will be a very very important, keep in your mind. Okay, so that is what a concept I want to deliver here. Okay, so this is what we call as the late deceleration, because the deceleration is happening late. Okay, so it is happening when the peak of the contraction. Okay, so here I have written the statement, so note it down. So deceleration is seen at the peak of the contraction. Okay, so at the peak of the contraction, so very very important. So that is what we call as the late deceleration. Okay, so if it's coming starting at the beginning of the contraction, that is the early. Okay, if it is begin, the fetal heart rate is start to decrease when the peak of the contraction, that is the late. Okay, so thousand time I have repeated because this is very very important, and in the next narset this question only it will come. Okay, so the late deceleration only will be asked in your exam. Okay, so very very important, because early deceleration already asked. Okay, image based question, and late this variable deceleration already asked, and only remaining image is the this one. So this is the very very important, so it will strikes in your upcoming narset 9. Okay, so it's in the narset 9 image based question. Okay, so after the exam I will come with the screenshot, right? Don't worry about this one, right? So hope you understood about the late deceleration. Sir, why the late deceleration is happening, sir? What is the reason, sir? What is the reason? Means it is happening due to the uteroplacental insufficiency. From when the uterus will contract very tight and very very tight, so that time what happens here, the blood supply to the uterus will get decreases. So blood supply to the uterus is decreases, means the blood supply to the all the nutrition and the oxygen supply to the placenta will decreases. So to the placenta blood supply and oxygen supply is decreasing, means to the fetus the blood supply and oxygen supply will decreases. So uteroplacental insufficiency, and which leads to the fetal hypoxia, or between leads to the fetal acid base imbalance, that is the fetal acidosis. Okay, so fetal hypoxia and fetal acidosis the very important thing, and which mainly happens due to the uteroplacental deficiency. If the image based question is not coming in your exam, so this particular point will come in your exam. Okay, keep in your mind. Okay, so late deceleration happens due to the uteroplacental insufficiency. Okay, so that is the very important. Then comes to the last type of the deceleration, that is what we call as the variable deceleration. Okay, so this is what we call as the variable deceleration. So what happening in the variable deceleration? The word itself is telling it is variable, means it is continuously changing. Okay, so students, this is the uterine contraction, and at that time the fetal heart rate is decreasing. That is the early, right? So this is the uterine contraction. Okay, so at the peak of the uterine contraction, the fetal heart rate is started to decrease. So that is the late. Okay, so consider this is the uterine contractions, and there is no relationship. Okay, suddenly fetal heart rate decreased, then again increased, suddenly fetal heart rate decreased, again increased, suddenly fetal heart rate decreased, again increased. So this is what we call as the continuously changeable or ununiform. It is what we call as the, it's not in the symmetric, it is not in the uniform way. Okay, we call this one in the ununiform wave patterns. Okay, ununiform wave patterns, so which will be seen in case of the our variable deceleration. Okay, so this is the very important thing, right? Here in the variable deceleration, the fetal heart rate is going less than 70 beats per minute. Very important. And there is no relationship between in graphs between the uterine contraction and fetal heart rate. Okay, so uterine contraction is happening on its own thing, and the fetal heart rate is decreasing here, again here, again here, again here. Very frequently a drop in the fetal heart rate will be there, so it is not actually uniform in the way. Okay, so which happens due to the umbilical cord compression, the very important point, bacho. Why the way this particular late deceleration is happening? So it's happening due to the umbilical cord compression. This is the very important point for your exam. Okay, so question will be asked in your exam. Focus, right? So then when the pressure from the card is released, so that time it will comes to the normal. Okay, so which comes to normal, okay, when the pressure from the card is released. Okay, so which happens due to the umbilical cord compression. Okay, so this is the image based question of the variable deceleration. Look at this one, bacho. Here your uterine contraction is there, so uterus started to contract and it's relaxed, then it started to contract, then it's relaxing. Okay, so this is the uterine contraction, and here is the fetal heart rate will be there. This is the fetal heart rate. Okay, so now uterus is started contracting here, means look at this one, the the very frequently fetal heart rate is dropped and it's gone back to the normal. Okay, fetal heart rate is dropped and it's gone back to the normal. And again you look at here, so there is no any contraction is there. Okay, so here there is no any contraction. Look at this one, there is no any contraction, still the fetal heart rate is dropped and it's gone back to up again. Okay, it's gone back to up again. Okay, but here is the uterine contraction is there, but there is no any drop in the fetal heart rate. Okay, it is normal. Okay, here again there is no any uterine contraction, sudden it's dropped. So because this variable deceleration, it's not happening due to the contraction, it's happening due to the umbilical cord compression. Okay, so here the umbilical, this time the umbilical cord is compressed, so because of that the fetal heart rate is decreased, so pressure from the umbilical cord is released, so it came back to the normal. Okay, so again the pressure on the umbilical cord increased, so it is the fetal heart rate is suddenly decreased. Okay, so when the pressure from the umbilical cord is released, so it came back to the normal. Okay, so again the pressure on the umbilical cord is increased, so it came back to the, okay, the fetal heart rate is less, but here it is decreasing less than 70 beat per minute. Okay, so it's an worst kind of the our deceleration, what we can say. Okay, so when the pressure released, again it came back to the normal. Okay, so that is what we call changeable deceleration or the variable deceleration. Very important, keep in your mind. Okay, so now identify the image now. Okay, so identify the image now. So this is your very important. Okay, so this is the image A. Okay, this is the image B. This is the image C. Okay, so look at the image. What happening in the image A? When the uterus is started to contract, in the beginning of the uterus, the fetal heart rate onset will be started to decrease, right? When it is in its peak, the fetal heart rate is nadir. Nadir means the lowest point of the fetal heart rate is called as the nadir. Okay, so what is the nadir? So let me write this nadir clearly. This is the nadir. Nadir means when the fetal heart rate in its lowest point, that is what you call the nadir. Okay. So nadir is associated with the highest point of the uterine contraction. Okay. So when the uterine contraction will start to reduce, so that time fetal heart rate went back to the normal. So when it happened, it happens due to the fetal head compression. That will be in case of the early deceleration. Yes. What we have studied this one only. Yes. So let's come to the option B. So that will be a uterine contraction is here. Okay, one uterine contraction, but the fetal heart rate is suddenly frequently decreased. So it went back to the normal. Again, it suddenly frequently decreased, went back to the normal. Again, suddenly frequently decreased and went back to the normal. Okay, it is completely not associated, which happening due to the fetal umbilical cord compression. That is what you call as the variable deceleration. This is what you call the variable deceleration. Okay, so comes to the third image. So that is the C image. Okay, so look at the C image, bacho. Here is the uterine contraction is there. Okay, at the peak of the uterine contraction, there will be a beginning of the or the onset of the low fetal heart rate will be there, and which is nadir is not associated with the peak point. Okay, so this is what we call as the late deceleration. These all things we have studied, and note these golden points for you people. Okay, so early deceleration will happens in case of the head compression. When it happens, yes, the early deceleration happens due to the fetal head compression. Very important point. Then a late deceleration which happens due to the uteroplacental insufficiency. Very important point. Then the a third point, variable deceleration, which happens due to the umbilical cord compression. Very important point for your upcoming exams. Okay, so this is the 5-star points. These are the 5-star points. Okay, very important for your upcoming exams. Keep it in your mind. Okay, so what all are the nursing responsibilities when we will get the non-reactive NST, or when we will get the non-reactive or the non-reassuring cardiotocography? So what I told, the first important thing is which in the cardiotocography, the fetal heart rate is varying or the decelerating, which is because of the increased pressure in the uterus. Okay, so the first thing is to reduce the uterus pressure. Means if during the labor, if we are giving the oxytocin, means first priority is to stop the oxytocin. Okay, so if any sudden decrease in the fetal heart rate or the fetal heart rate suddenly start to reduce, okay, the question will comes. Okay, so you are a nursing officer assisting a woman in the labor. Okay, when you will look at the CTG monitor, that time the fetal heart rate is start to decrease. What is the nursing responsibility? The priority nursing responsibility will be asked in your exam. The first priority is stop the oxytocin infusion. Okay, so first priority is to stop the oxytocin infusion. Then the next second priority is the suddenly or immediately start the oxygen. So what is the rate of the oxygen? What we have to give is the 8 to 10 liter per minute. So we have simple face mask. Okay, so we have simple face mask, we have to give this one. Okay, so then the third priority is to turn the mother to the left lateral position. Okay, so if you found any umbilical cord is get prolapsed, so then the turn the mother to the trundle bug position or the knee chest position. If there is no any prolapse of the cord, so the left lateral position is the perfect position. Okay, so in order to reduce the supine hypotension syndrome. Okay, so then the fourth priority comes to the inform to the primary healthcare provider and the start the IV fluid. Okay, so that's the very important. Okay, so what are the patterns where we will recommend for the lower segment cesarean section? Okay, so where we will recommend for the LSCS. Okay, LSCS recommendation. So in case of the patient heart rate is sinusoidal heart rate pattern, so means the patient is having the this kind of the heart wave pattern. Okay, so heart rate pattern is like this. So this is what we call the sinusoidal heart rate pattern, so which will be seen in case of the RH incompatibility and which will be seen in case of the vasa previa. So immediately we need to deliver the baby with the help of the cesarean section. Okay, if in case of the late deceleration. Okay, so when the late deceleration we will see in case of the uteroplacental insufficiency. Okay, so yes, a patient is getting the less blood, or sorry, the fetus is getting the less blood inside the uterus, means the fetal will get the hypoxic encephalopathy and the fetal may get die due to the lack of the blood supply. So in order to prevent that one, immediately we have to go for the lower segment cesarean section. Very important thing. Okay, if in case of the variable deceleration, the umbilical cord is get prolapsed or the umbilical cord is get compressed, so again the blood supply to the fetus is reducing. So the next very important thing what we have to do to immediately prepare for the LSCS. Okay, so the next one, very important one, that is the bradycardia. So in case of the bradycardia of the fetus, again, so it indicates in the fetal hypoxia. So again, we will go for the LSCS as the management. Okay, so these are the very important things what we have discussed today. And the most important part of the today's discussion is the yes, image based questions which are repeatedly striking in your exam. So I have cleared everything that is required for your exam purpose. Hope this class will help you people and it will fix your at least 2 to 3 questions from the OBG. So in your upcoming exams. And every one of you hope enjoyed this particular class. If any of one of you are watching the master nursing classes first time, so please do hit the like button and subscribe to the channel, so it will bring you a good rank in the upcoming days. So we will meet again in the next very bouncer session. So tab tak ke liye jai hind, jai bharat, bye bye, take care, love you all. Don't forget to subscribe to the channel. And if you are watching for the perfect theory classes, yes, link is there in the app link is there in the description box. You can go through the description box, and the Norset 9 test series also available. SGPGI KGMO perfect fixed and syllabus wise planned, nursing and non-nursing both syllabus covered test series are available in the app. If you want to become a part of that one, join today, so it will boost your rank in the exams. So let's meet in the next session. Tab tak ke liye jai hind, jai bharat, bye bye, take care.